I am delighted to speak with you today about severe asthma. What is it and how to reach the diagnosis?
Okay,
My disclosure are here with funding from NHLBI, consulting from AstraZeneca and GSK, and funding for the study from AstraZeneca. This is the outline of my talk, describing the feature of severe asthma, how to reach the diagnosis, key finding from the Severe Asthma Research Program, and finish with summary and future data. Let me start with this patient case history. 45-year-old man, history of asthma since childhood with allergies, chronic rhinosinusitis, used albuterol and ICS intermittently over the years. Seen in ENT clinic for increased productive cough and presumed sinusitis, and treated with antibiotic, prednisone, antihistamine, and nasal steroids, with good improvement initially. When cough returned, he was started on ICS LABA, but cough persisted. He was seen in pulmonary clinic for evaluation of difficult to control asthma. His parameter was normal, and we did a chest X-ray. As you can see, the X-ray had faint infiltrate in the upper lobe, particularly in the left side, and the CAT scan confirmed this upper lobe consolidation. So it's clearly that this patient probably is not dealing only with asthma. So laboratory finding included IgE, which was normal, Aspergillus normal, ANA, ESR, and ANCA, they're all normal. And white count was 14.7 with 45% eosinophil. So he had significant eosinophilia. And at this time, you wonder, is the diagnosis really severe asthma? And the answer is probably not. This person has chronic eosinophilic pneumonia. We treated him with 40 milligram a day of prednisone with a dramatic improvement. Here are the key questions that you have to ask when you see a patient with difficult to manage asthma. First and foremost, does the patient have asthma? Because as we have seen, some patients who are referred for difficult to manage asthma are not dealing with asthma. Is the patient taking the medication appropriately? Does the patient have alternative diagnosis of comorbidities? And only if asthma remains difficult to manage after all of this, then the patient probably has severe asthma. So let's start with, does the patient have asthma? We know that to diagnose asthma, we need a history of wheezing, cough, chest tightness, congestion, dyspnea. And most patients have allergies, things like house dust mite, cats, molds, and exercise-induced asthma, especially when they're in the cold, dry air, and nocturnal asthma. Patients with asthma typically have airway obstruction, and that improves with inhaled bronchodilators. And they also can be demonstrated to have airway hyperresponsiveness to methacholine if need be. We also need to consider alternative diagnoses such as vocal cord dysfunction, COPD, CHF, interstitial lung disease, reflux, obesity, sinusitis, anxiety. All of this can contribute to or mimic asthma symptoms. The inadherence or inappropriate use of medication is a very important problem when patients with asthma don't improve. There are a number of inhalers on the market, and this picture is from a few years ago. And even then, there were too many inhalers for most patients to master, and therefore the inhaler technique is suboptimal in many patients, and that results in less bioavailability of the drug to the patient and less improvement. The ATS-ERS workshop on severe asthma defined it as asthma that requires treatment with high-dose ICS plus a second controller or oral steroid to prevent it from becoming uncontrolled, or asthma that remains uncontrolled despite this therapy. They suggested 3 steps: confirming the diagnosis, differentiated mild from severe, and evaluating the asthma control with regard to the symptoms, exacerbation, or airflow limitation. More than 20 years ago, the NIH established the Severe Asthma Research Program, and now it is in the 4th cycle of funding, started in 2019. The job was to improve the understanding of severe asthma to help develop better treatments. This is a network of a number of clinical sites and a data coordinating center. There is a data safety monitoring board to review protocols, monitor safety and adverse event, and oversight by NIH scientific officer. The first paper published there was a characterization of the cohort. This was reported in 2007. And at that time, we had about 400 patients divided into mild, moderate, and severe. And as you could see, the patient with severe asthma were older, and they have asthma for longer duration. Also, these patients had significantly lower FEV1, greater obstruction, but had clearly significant improvement following inhaled bronchodilators, although their best lung function was still not completely back to normal. These patients were using a number of medication. 98% were on ICS, 89% on LABA, so majority of them were on 2 controllers, and 50% were also taking a 3rd controller. Despite these medications, they had significant healthcare utilization, with severe asthma patient shown here in the black bars, requiring more frequent visit to the emergency room, hospital, ICU, or ventilated use, whether it was in lifetime or in the past year. So severe asthma is characterized by airway obstruction with reversibility, persistent ongoing symptoms, in addition to a history of previous infections. They're almost always in a 2nd controller therapy. They have increased healthcare utilization and potentially life-threatening exacerbations. In a subsequent study of 725 asthma patients, we looked at 34 core variables, which we analyzed using unsupervised hierarchical analysis. This yielded 5 clusters of asthma. All of these clusters contain patients with severe asthma, confirming that severe asthma is somewhat heterogeneous. Schematically shown here is the 5 clusters with a distribution of mild, moderate, and severe. And you can see the mild were more segregated to cluster 1 and 2, while the severe was more seen in cluster 4 and 5. While we required 34 variables to assign a given patient to a cluster, it turned out the most important variables were baseline FEV1, improved FEV1 post-bronchodilator, and the age of onset, which for the most part can be assigned patient to one of these 5 clusters. The key feature of these 5 clusters are shown on this slide. Cluster 1 is for early onset atopic asthma with normal lung function. Cluster 2, mild to moderate allergic asthma with borderline FEV1 but normalized after inhaled bronchodilator. Cluster 3 is more severe, tend to be older, more obese, and less atopic. FEV1 is reduced with some reversibility. Cluster 4 is more severe, variable, it's early onset, and there's decreased FEV1, but reversibility back to normal. But these patients have a lot of symptoms and need for oral steroids. Cluster 4 is older asthmatics with longer duration of disease, less atopy, more severe obstruction, less reversibility. So they really look very much like COPD. In SARP, we were also able to obtain a number of imaging studies, mostly focused on CAT scan, and that resulted in several publications and journal covers. On this slide is an example of one of our CT studies that correlated airway wall thickness with air trapping and biopsy obtained from the same segment. The upper panels is a patient with mild asthma, and in the lower panel is a patient with severe asthma. The mild asthma patient had a thin airway without significant airway wall thickening. And when looked at air trapping, as shown here by the green color, there was limited air trapping. And on biopsy, the thickness of the lamina reticularis was modest. On the lower panel is a severe asthma patient where the airway walls were thicker. There was more air trapping shown with the bright green colors, and there was thicker lamina reticularis showing increased airway remodeling. Also, CT scan was used to detect mucus plugging. We know that patients with severe asthma can have bronchial casts that they sometimes cough out, and the picture of one of those is shown on the left side of this slide. But also with CAT scan, airway that appeared plugged are shown here with a circle around it to demonstrate that white areas that are mucus-filled airways. In this study, we evaluated the number of airway segment with mucus plugs in patients with asthma and correlated these with the presence of eosinophils and airway obstruction. As you can see, the CAT scan example on the left side showed airway that are plugged with mucus, shown in the white, and marked by the yellow arrows, either in longitudinal or cross-sectional profile. When we looked at the FEV1 as an indication of airway obstruction, we find that patients who have no mucus plugs, this is the 0 mucus plug score, had the best FEV1, as opposed to patients with the highest mucus plug score. These are people with 4 or more segments that have obstructed mucus that have the lowest FEV1% predicted. Therefore, mucus pluggings did correlate with the presence of airway obstruction. In addition, mucus plugs were associated with the eosinophil products. On the left side, the A figure, there's a correlation between sputum eosinophils and their granule protein EPO, or eosinophil peroxidase, among patients who are healthy and asthmatics. And you can see that EPO level increased as the percent of eosinophil increased, with a pretty significant correlation value. On the right side, the B figure, are patients who have 0 or high mucus scores compared to normal subjects. And as can be shown, the patient with the highest mucus score had also the highest level of eosinophil peroxidase. This confirmed that the presence of mucus plugs correlates with the presence of eosinophil product, in this case, eosinophil peroxidase, or EPO. As previously discussed, asthma exacerbation are very important, and each year in the US there are 15 million visits to clinics for asthma, 2 million ER visits, and 500,000 hospitalization for asthma. These exacerbations are associated with high healthcare costs, burden to patients and their families, and the potential for greater decline in lung function with increased risk of morbidity and mortality. We also looked at risk factor for asthma exacerbation in SARP-3 as well as SARP-1 and 2. In these two cohorts, the risk for exacerbation was clearly increased in patients who have GERD or acid reflux, obesity or greater BMI, and blood eosinophil, increase in blood eosinophils. So these are the key risk factors for asthma exacerbations. We also looked at asthma exacerbation over a 3-year longitudinal study. There were 400 plus patients in this SARP-3 cohort. What we found is that 21% have had an asthma exacerbation at least once every year of the 3 years. These were labeled as asthma exacerbation prone patients, and 41 had no exacerbation in any year, and these were labeled as exacerbation resistant asthma. The exacerbation prone asthma was characterized by lower FEV1, presence of metabolic syndrome with obesity, diabetes, hypertension, and higher level of IL-6. Shown here is a graphically demonstrated occurrence of exacerbation over time, year 1, year 2, and year 3. In the green is the exacerbation resistant asthma. These are people who did not have exacerbation in the first year, second year, or third year, shown in the green color. The red color below are patients who had exacerbation in every one of these 3 years, and the orange color is for people who had exacerbation in 1 or the other years. And as noted before, 41% were exacerbation resistant, 21 exacerbation prone, and 38% exacerbation intermittent. And the best predictor for exacerbation in any subsequent year is having had an exacerbation in prior year, something that confirmed findings from previous studies. We also looked at biomarkers, starting with IL-6 in these patients, and found that in a cross-sectional analysis in the 2 cohorts with high and low IL-6 level, patients who had high IL-6 had higher BMI and more hypertension and diabetes as compared to patients with low IL-6 level. In addition, patients with high IL-6 levels had worse lung function and more frequent asthma exacerbation compared to patients with low IL-6 level. The next biomarker I'm going to mention is sputum granulocyte. This is an indication of inflammation with either increased eosinophils, increased neutrophils, or both. And what we notice is if you look at the patient who have increased eosinophil more than 2% and increased neutrophil more than 40%, these are called mixed granulocytic inflammation. These patients had lowest FEV1 down to 66% of predicted, and they had 70% of them had urgent care visit during the past year, 25% had ICU admission, and 50% had daily wheezing. So this highly inflammatory phenotype has the greatest impact on patient symptoms, lung functions, and healthcare utilization. So how do we evaluate patients when they come to us with uncontrolled asthma? As I mentioned before, it's important to go systematically, consider other diagnoses such as core dysfunction, COPD, heart failure, etc. Evaluating triggers, namely allergens, drugs, irritants, reflux, or comorbidities, sinusitis, obesity, sleep apnea, VCD, which can be coexistent with asthma, anxiety, and hyperventilation or dysfunctional breathing. Once we looked at all of these, and you're left with people who have ongoing symptoms, then you're probably dealing with severe asthma. So to summarize, severe asthma patients are typically older with longer disease duration, often women, although in some studies we did not find predominance of women, but generally women are more affected with severe asthma. There is an association with persistent symptoms and airway obstruction despite treatment with high-dose ICS and LABA. The diagnosis requires a careful history, evaluation of alternative diagnoses, evaluation of comorbidity, and assessment of adherence to medications. Additional testing such as CT scan may be required, mainly to exclude other diagnoses such as interstitial lung disease. The key finding from our research studies is that severe asthma is a heterogeneous disease with different clusters and phenotypes. CT scan have shown airway involvement to be regional. There is a airway wall thickening in some spots, air trapping, and mucus plugging in certain segments, not in all segments. There's inflammation, particularly when mixed granulocytic, that is associated with worse asthma outcomes, less FEV1, and greater symptoms and healthcare utilization. Elevated level of IL-6 in severe asthma correlate with more airway obstruction and frequent exacerbations. And these findings have provided rationale for ongoing trials of biomarker-based severe asthma therapy that will hopefully lead to improved management of severe asthma in the near future. Thank you for your attention, and I greatly appreciate the invitation to be with you today.
Thank you very much.
I am delighted to speak with you today about severe asthma. What is it and how to reach the diagnosis?
This is repeating the recording. Our speaker actually is sleeping right now at 3 o'clock in the morning where he is, and he's having sweet dreams. He's sending his regards. We'd like to move on to the next session. Our next session is on severe asthma. Who should receive which biologic and why? Current and future approaches in severe asthma patients is the title of the next session given by Professor Param Nair, who is a professor of medicine at McMaster University in Ontario, Canada. He is a consultant respirologist at St. Joseph's Healthcare in Hamilton, Ontario, and it's a pleasure and honor to have you with us, Professor Param.
Thank you very much indeed. we have almost forgotten how to participate in in-person meetings. It's a pleasure to be here and to deliver this lecture in person. These are my conflicts of interest pertaining to this particular lecture. My university holds grants from a number of pharmaceutical companies who make biologics. I have received honoraria and speakers' fees for participating in science